Hi everyone, my name is Renee McConnell, and this is my audio recording for primary patient assessment. Before arriving on scene, I will have my medium-sized glove on and my glasses on for my BSI. If PD has been dispatched to my scene prior to our arrival, I will stage in an area that is close but not too close. Once PD has confirmed that the scene is safe, I will enter. Upon arriving on scene, I will conduct my own assessment to ensure the safety of myself and my partner and any other first responder on scene. If PD has not searched my patient for weapons prior to my arrival, I will ask that they do so at this time to ensure everybody's safety for any weapons such as guns, knives, needles, and lighters. I will also note the time of day. I will note the behavior of my patient and any bystanders. If there are bystanders on scene, I will utilize them for any helpful information related to my patient. I will consider the weather on scene. That way it will aid in my possible diagnosis, such as if it's hot outside, is my patient having a heat stroke? If it's cold outside, is my patient hypothermic? If it's raining, could my patient have hydroplaned and causing the vehicle accident? I will also note my environment and whether it is enough room for me to perform what I need to do for optimum patient care. I will note if there are any obvious mechanisms of injury or the nature of the illness. While also scanning the environment, I will note the cleanliness of my environment. While I am scanning the environment, I will note the number of patients that I have on scene. With getting a patient count, I will note the state of my patient and their personal hygiene. I will also notice if the patient acknowledges myself or my partner once we approach them. I will look for any clues on scene that may indicate the nature of illness or the mechanism of injury. If I believe that any additional resources are needed, I will ask dispatch for them to be dispatched at this time. After having additional resources sent, I will consider the stabilization of my patient's spine. If I believe that they need to be immobilized, then I will do so at this time. By now, I have a generalized impression of my patient. I have obtained my patient's gender, age, and weight. I have already noted my patient's appearance, facial expressions, and whether the patient has made eye contact with me or not once we have arrived on scene. I have noted the patient's dress and personal hygiene. I will notice if they have any vomit on them or if they have urinated themselves. If the patient is experiencing any difficulty in breathing, I will note how many words they are able to speak per sentence. If they are having any abnormal sounds such as stridor or sitting in an abnormal position such as tripod, I will also note if they are having any retractions or using any accessory muscle usage to assist in breathing. I will also note any nasal flaring in my patient as well. At this time, I should determine my patient is a load and go or a stay and play. I will assess my patient's level of consciousness or responsiveness by asking the appropriate orientation questions, such as if they can tell me their name, where they're at, what month it is, what day of the week it is, and who the president is. I will also notice any life threats to my patient. If there are none, I will ask the patient what's going on today and why they called 911. If the patient did not call 911, I will ask who did call and why. And I will also note who the historian is. Is it my patient? Is it a family member? Or is it a bystander? With asking the patient questions, I've been able to establish the patient's airway and breathing status. If the patient is unable to answer appropriate questions, then I will ask the patient's family or bystanders that may help aid in this. I will also assess the patient's respiratory rate, depth, and notice equal chest rise and fall. If the patient is in need of oxygen, I will administer the appropriate amount, whether it be by a nasal cannula, non-rebreather, mask, or nebulizer. Once I am done assessing the airway and breathing status, I will move along to assessing the patient's circulation. I will note any life-threatening bleeding and tend to that with either a pressure dressing or tourniquet or apply direct pressure. I will assess the patient's skin color, temperature, and texture with the medical handshake. I will note the patient's turgor, and I will also note the patient's pulses. If I am unable to palpate a radial pulse, I will check the carotid artery. If my patient is unconscious or in a cardiac arrest, I will check the carotid pulse first, or even listen to the apex of the heart with a stethoscope. I will note if the pulse is regular or irregular, or if the pulse feels like it is tachy or brady. I will assess the patient's disabilities that the injury may have caused. I will also assess the patient's pupils. I will note if they are reactive to light, if they are dilated, or if one pupil is blown that may indicate a head injury. I will now expose the patient's chest in order to obtain at least a 4-lead EKG. I will do a 12-lead EKG if it is warranted. I will also expose the chest in order to be able to clearly listen to lung sounds. With exposing the chest, I will also note if there is Gray-Turner sign or Coven sign after a traumatic injury. By this time, I am definitely able to tell if my patient is a stay or play or a load and go. If they are a load and go, I will perform more lengthy assessment or treatment en route to the facility. As part of my assessment, I will ask the patient when the onset of their symptoms began, what they were doing when all this started, or if anything makes it better or worse. I will ask the patient to describe the pain and rate it on a scale of 1 to 10, with 10 being the worst pain they have ever experienced. I will ask the patient to show me where the pain is, if it moves or radiates, and if it is reproducible with inspiration or expiration. I will also ask the patient if the pain is constant or does the pain change. I will inquire if the patient has self-medicated with any over-the-counter medication or by any other means that they thought might be a good idea. I will also find out if the patient is experiencing any chest pain or difficulty in breathing. Now I will obtain the patient's medical history. I have found the best way to ask this is to ask what the patient takes medication for. I will ask the patient if they have any allergies and possibly what the reaction is. I will make sure to get the patient's medications. A list to take to the hospital would be best. I will find out the patient's compliant with the prescription if they've taken their medication today. I will also ask the patient if they have had any similar episodes to the one they are experiencing, or if they have had any recent surgeries. I will also ask the patient when their last oral intake was. I will inquire what the patient was doing when the symptoms were started. And I will ask the patient non-accusingly way if they use recreational drugs, enjoy alcohol, smoke, or chew tobacco. If the patient uses recreational drugs, I will ask what they use and when the last time they used. If the patient admits they are a heavy drinker, I will ask when their last drink was. With a secondary assessment, the brain, lungs, and heart should have already been assessed since you checked them from the start. I will assess for JVD, check C-spine, and to make sure everything is midline. If I have not checked lung sounds by now, which I already should have, I'll expose their chest to do so. I will listen to their heart tones. I will also make sure that pulse, motor, and sensation are intact in their extremities. I will also check their cap refill and look for any pedal edema. I will check the other organ systems as needed per the chief complaint at this time. Finally, it's time to take some vital signs. I will check a temperature, pulse, and count respirations. I will also check a patient's blood pressure. I will start out checking with a manual blood pressure, and then I will possibly do an automatic pressure on the way to the hospital unless it's a chest pain call or I have an abnormal blood pressure. I will check their oxygen saturation. I will note if the patient's fingers are cold or if they have fingernail polish on, since that will give me a false reading. I will check the patient's glucose and check the patient's CO2. I will do an ECG with appropriate reasoning, such as chest pain, difficulty in breathing, or anyone with a positive cardiac history. I will note if the skin is pink, warm, and dry, if there are any lacerations, contusions, or bleeding. If it is related to the cheek complaint, or if I suspect a loss of consciousness, I will ask the patient if they remember everything that happened. I will pay close attention to the patient's eyes, whether they are glazed over, bloodshot, or abnormal in any way. By now, I have established my general impression of this patient. With my differential diagnosis, I will begin to treat the patient based off of my differential diagnosis. I will begin to treat my patient. If I need orders that I don't already have standing orders for, I will call my medical command. If at any time at all that I question myself on what I am doing, or I just have a question that maybe I just forgot, I will call my medical command and get directions. After all this is said and done, I will reevaluate my transport decision. And I will repeat my primary survey of my patient. I will repeat my vital signs en route. With repeating vital signs, I should check vital signs every 15 minutes on a stable patient and every 5 minutes on an unstable patient. By this time in the transport, I have noticed if my interventions have been successful. I also need to evaluate my patient for any change in status. Finally, I need to repeat my secondary assessment in regards to the patient's chief complaint. All this should be done in order to successfully have a patient evaluation.